2022. Can I ask all of you who are not going to talk to just mute yourself for now? There seems to be a lot of echo at the background. Okay, so welcome again. This is our first program of the year 2022. As you all know, we are once again facing a massive wave of COVID-19, and there are several things that are different about this disease this year. We have been battling this disease over the last 2 years. We are learning as we go along, and we really need to keep updating ourselves because things seem to keep changing all the time. We have had several programs before looking at the management of children with COVID-19, looking at the post-inflammatory syndrome that occurs after COVID in many children, which is a common problem with children. But I think now the topics we have chosen today are topics that have not been discussed previously in any great detail. So first of all, Dr. Mihi Sharkar is going to talk about the new genotypes. What do they mean? What are the implications? And then all these multiple drugs that we are hearing about, do they have any role at all, especially in children? And then secondly, we have a panel of experts to discuss day-to-day management of children, both preventive management and the treatment part of it, especially with special regard to the high-risk children that many of us have to deal with. So thanks for attending, and I'm sure it will be a learning experience for all of us. Indranil, back to you.
হ্যালো হ্যালো
Yes, শোনা যাচ্ছে।
আমি কি বলবো এখন সুস্মিতা দি?
Yes, please go ahead.
Good evening and welcome all to the new year 2022 from WBAP, and this is our first webinar on behalf of WBAP, and we have chosen the most important what is going on around the corner, that is COVID, Omicron and Delta, and we'll be trying to bring you all the experts in the field here who are now working day and night for the COVID medicines, new researches, the way they are working. And at the same time, I would like to tell you that COVID is also been in a very, in the same mode in the districts. And here in all the government hospitals and private hospitals in the districts throughout West Bengal, doctors are working, pediatricians are working in a infrastructure-less arena. I think our panelists and our experts will, remember them during their talks, how important it is for them to be discussed about. Now, firstly, we have the lecture by Dr. Mihir Sharkar. He is from Calcutta Medical College. Then we have a panel discussion on the same subject. We have as experts Dr. Apurva Ghosh, Director ICH, Dr. Amitabh Pahari, Senior Consultant Pediatrician from Apollo Hospitals. In the panel, we have got Dr. Orpita Bhattacharya from Tata Medical Center, Dr. Amitabh Chatterjee from Narayana Hospital, Howrah, Dr. Giri, Giri from Institute of Child Health, the Pediatric College, Professor, renowned pulmonologist, pulmonology pediatrician, and Dr. Arundhati Banerjee. She is from Calcutta Medical College. The whole session will be moderated by Dr. Banerjee, who is also the president of WBAP 2022. I welcome all of you, all audience, to kindly be with us. Please mute your mobile phones so that we don't have any extra thing. I hand over to Dr. Mihir Sharkar for his speech. Thank you all.
Very good evening, everybody, my teachers, my seniors, my colleagues. Am I audible?
Yes. Yes, you are. You are audible. Carry on.
Okay, just a minute. My PowerPoint presentation is not shown at the time. Okay, just give me 1 minute.
No problem, Mihir.
Is it visible now?
Yes, fine. Can you go to slide share mode? Yes, perfect.
Thank you, Susmita madam. Thank you, Indranilda and whole team of WBAP for giving me this opportunity to talk on this topic. So now today's topic is this COVID-19, what is new in this new year 2022. And especially I will highlight on the new genotypes that is being discussed all over the world and the drugs that are available and if they are really useful in managing the children. So all over the world, from every corner of the world, you can now have an idea that is the omnipresence of this virus variant that is called Omicron, and there is tsunami of the cases all every corner of the world, and also there is tsunami of cases from India. And few people says is not a tsunami, but it's just an explosion. So now today's point of discussion will be the Omicron, how it is different from other variants and the past waves. Vaccination, is it going to help us? And also the children, and testing about the this variant, what is new, and the management, is there any magic drug, and is there any shift of this approach to the pandemic? So you all know these variants of concern that has been declared by the WHO over the various time frame, and they have this original U1 variant is called this B11, and then alpha. After that, first the variant that appeared is the alpha, which had the around the 10 mutations, and the beta, which has also the 10 mutations. Then after that, the gamma variant, which came from the Brazil, it had the 12 mutations, and the delta variant that actually discovered in the end of 2020, that in October from India first, and it had 10 mutation, but it's that the severity of the disease was high, and almost all countries had faced this delta pandemics and the delta wave. Now the new variant, which is called the B11529 as the Omicron, is the first detected in November from the South Africa, which has the as many as 30 mutations in only the spike protein, but there are other mutations also in the other proteins of the surface envelope protein or E protein. If you look at this, the timeline of the Omicron is the first, it was detected from the South Africa, Botswana of the South Africa on the 14th November. And then the WHO declares the variant of concern in November 26. And the India, the first case detected in the 2nd December from Karnataka, and the West Bengal, incidentally, it was a children with a 7-year-old boy tested positive in the 15th December. But after that, we have got the tsunami of the cases, and now the tally going to the around 2 lakhs per day. So why it is called the variant of concern? Because this, if we call it a variant of concern, if it has the property of easier transmission, if it induces the severity of illness is increased, or it reduces the reduced neutralization by the antibody is there, and thus reduce efficacy of the drugs and the treatment, and reduce efficacy of vaccine or the vaccine escapability. So Omicron have the severity of the disease is less, but otherwise the all four criteria are made by the Omicron. So that's why it is called the variants of concern. And if you look at the mutations, this Omicron has at least the 32 mutation in the spike protein, and the most of these are the substitutions, and there are 3 small deletion and 1 small insertion. The most important thing is that the receptor binding domain of the spike protein, which is the main concerns of this, our target of monoclonal and the vaccines, are mutated. And there are at least 10 mutations in this receptor binding domain. So this is you can see from this picture, there are 10 mutations from this receptor binding domain, and there is more than 32 mutations in the spike protein. So these are the I'm not going to the details. So this is the deletion, that is the one of the nucleotide is just deleted. Then insertion is that one extra nucleotide is inserted, and substitution, that one nucleotide is replaced by the others. So this is just the basics of the genetic background. So if we look at this Omicron spike protein here, this is the spike protein of the Omicron, and what is the difference between the previous strains, that is Delta, and this is the Omicron. You can see here that there are lots of mutations. So there are, and that's why, and total mutations are said to be more than 50, and only the spike protein have the 32 mutations. So that's why the many scientists and the many researchers are calling it is not a antigenic drift, but it is an antigenic shift in the midst of pandemic. And as said by Dr. Jacob John, it is not a variant, but it is a deviant. It is totally deviated virus from the normal mutation pattern of the SARS-CoV-2. So if you look at this, the lineages of the SARS-CoV-2 here, you can see this, the original Wuhan is the B11. From there, the different lineages, this is the alpha, beta, gamma, and they appeared, and they have the correlation, and they are mainly linked to the original. But if you look at the Omicron, there is a long time gap. There is no change is detected, but after a certain point of time, there is huge numbers of changes are observed. That's why some of the scientists are calling it is a new deviant or the new genetic shift. It is a totally genetic shift, and also it is maybe a new virus event. So that is the basis of this Omicron, why it is totally a new, looking like a new virus, and it is deviated from the normal mutation pattern of this Omicron, other variants of the Omicron. So what are the highlights of the Omicron? What do we know about it till now? It is the most transmissible compared to the other variants. The Omicron is dodging the immune system. It may be the natural, it may be the vaccine or the hybrid immunity, that is the vaccine plus the herd immunity or the natural immunity. So, and it has significant reinfection risk of the Omicron, that is 5.4 times more than the Delta. And doubling time is just 1.5 to 3 days. But less disease severity is been noted, but we should be very cautious, and the WHO already given the cautious that it may not be that. So over the time, we have to have a vigilance of how it is behaving, and it may be looking at the high number of cases, a significant number of patients may get admitted and may require ICU care. So why does Omicron is more transmissible? It has been shown if you look at the reproduction number, that is, it is around 4 for this Omicron compared to the Delta combined other variants, which was only 1.32 to 1.09. So you can see that the transmissibility is very, very high in case Omicron. So what is the genetic basis of this high transmissibility? It has been shown there's the studies, the animal studies have shown that the Omicron, the deep tissue penetration is less compared to the bronchus or the upper airway. So it is mainly concentrated to the upper airway. And the mutation that enhances the spike protein cleavage, as these are the 3 mutations that enhances the cleavage of the spike protein, that is responsible for more transmissibility. and mutation that enhances the binding of the to the AC receptor of the virus. So these two mutations, the N501Y and the Q498R, they combine, they increases the enhancement of the binding of the virus to the AC receptor, and these are the basis of the high transmissibility of this virus. So what is the real world evidence? As you know, this is the UK data. Is shown that the green is the Delta variant and this purple is the Omicron. So over the time, the Delta has been suppressed by the Omicron, and Omicron is the predominant variant all over the UK and all over the world. So it has very, very high transmissibility. And this is the USA data. You all know that on 3rd January, there was 10 lakh cases in USA. But compared to that, the mortality death was low, around 1693. So there is decoupling from the number of infection to the severity of death. But if you look at the hospitalization and intensive care, still you can see that the intensive care requirement is 20,000 here in USA. So if the India faces the similar problem, and the cases goes to that extent, then there may be some crisis of the ICU beds even. So though the less disease severity is less, but the high number of cases can lead to increased hospitalization and ICU care. So this is the Indian scenario, though it is a data on 6th January, but now the cases are going to the 2 lakhs per day. And from the genetic genome sequencing study have shown that this Omicron variant in various metros in India are around 80 to 85%. So it is replacing and now even it is going to 90%. So it is replacing the other variants. So there's a high transmissibility. So now the question is how is this rapid evolution occurred, and where it occurred, and which are the conditions that fueled it? So what is the origin of the Omicron? Why the Omicron is so different from the other variants that I have already told that the scientists are thinking that it may be a totally new virus, but these are all hypotheses, and there is less hardcore evidence about that. And the variant seems to be evolved parallelly to the other variants like the alpha beta, but it was not detected. And it is always very difficult to identify who's the patient zero from where the variants appeared. So there are many theories. So one of the theory is that it's evolved and undetected in isolated population. That is in a population where the genomic surveillance is very weak or absent. The people are infected and less severity, and they are not detected, but the virus is mutated in them, and then it is getting this shape. So that is one of the theory, but it is always difficult to get the first patient is the patient zero or for a variant. And then the theory number 2, that you all know that as it is originating from the first detected in South Africa, the scientists thought that it may be the first multiplied in the immune suppressed patients like the cancer or the HIV patient, where they persist for a prolonged time, and then they got mutated because the healthy helper CD4 cell and the natural killer cells are less in them, so they get virus got a longer time for mutation, and this havoc mutation has occurred in them. And the third and the most robust that has been theory is that it evolved in animal host and jumped back, like the original Wuhan variant that was in the bat, and this variant, the COVID SARS-CoV-2 has then gone to the animals, and in animals they have mutated and come back to the human. So it is the human to animal, human to animal, and then again to animal to human transmission that has led to this massive mutation of this virus. But thus all are theoretical. There is hardly have any hardcore evidence. So what are the symptoms of the Omicron? The symptoms of the Omicron, you all know, these are different from this Delta. As you know that there are main difference that has been observed till now. That is, there is no published at least data till now, but the scratchy throat or the sore throat, the malaise and the headache, stuffy nose and low-grade fever, but sometimes it may be the high-grade fever for persisting for 2 to 3 days, extreme malaise and the weakness, and it persisting mostly for 2 to 4 days. But it is to be remembered that the manifestation of the Delta, like the loss of taste or the smell, that are less here in Omicron. The breathlessness or the hypoxia incidents are very less. And the cough was in Delta was dry cough, but few scientists or experts says that the cough and the observation says the cough in the Omicron is the moist or the productive cough. So these are the first, the few clinical manifestations that can alert us that this may be Omicron. So is there any pediatric data regarding the clinical presentation of the Omicron? So there is, I have not found any published pediatric data, but is my own experience that I was recording all that data of the patient that I have done teleconsultation in this period, around 40 patients. So this the most of the fever was most of the time there's less than 102°F, but in few patients, there is more than 103°F and associated with rigor. Duration is mostly less than 3 days in 36 patients, but few patients is going to have a fever more than 5 to 6 days, but the number is less. The stuffy nose, running nose, or sneezing, this combination is found is almost 90% patients. Sore throat that is less communicated by the children. Cough is present but less. Myalgia and irritability is a complaint with the most around 28 patients. Diarrhea and abdominal upset is found is around 1/3 of the patients. But in hospitalization data is in medical college that we have admitted around 12 patients. 2 patients are critically ill. One has AES with myocarditis, AKI, and hepatic dysfunction and require mechanical ventilation. No other etiologies have been identified till now for this patient, and 1 patient had diabetic ketoacidosis. Other patients are incidentally detected as COVID SARS-CoV-2 in patients with other diagnoses. So this is the one animal study that says that indicates that proves that the Omicron causes the less disease severity in human. So how this data of this animal studies in hamster and mouse have shown in this picture, you can see this is the Delta variant, and this is the picture of the lung of the Omicron. You can see in the Delta variant there is a lot of inflammation and hemorrhage in the lung, but it is it is not found in the Omicron. So you can see the lung pathology is totally distorted. There is the inflammation, and a lot of inflammatory cells are migrated into the lung tissue, but there is hardly any lung inflammation here in the Omicron. If you look at the histopathology, again, the difference between the bronchus and the alveoli and bronchus, in the this Delta variant is upper panel is the lung is inflamed and there is distortion of the lung parenchyma architecture, but that is in Omicron, it is almost maintained. But if you look at the bronchus, the inflammation is more in case of the Omicron here. So that's why the transmissibility of the Omicron is high than the Delta and other variants. Also, it has also been corroborated in the CT scan of this animal. You can see this is in Delta variant, the peripheral lung tissue. You can see the opacities in the peripheral lungs in the Delta variant. But in the Omicron, you can see there is hardly any peripheral opacities. It is mainly the perihilar opacities are there. And also the lung CT score, you can see the lung CT score in the red one is the Omicron and the black one is the Delta. And the lung CT score is significantly low in the Omicron. So again, the same thing that has been showed in another animal studies that the Omicron variant is replicated around 70 times higher than the Delta variant in human bronchus. And in contrast, the Omicron variant replicated less efficiently in human lung tissue. You can see here in the bronchus, the blue line is the Omicron and this orange line is the Delta, and this much higher in the bronchus. But in case of lung, the Delta variant is more infiltrated in the lung than the Omicron. So the one data from this UK, the clinical microbiologist, then the expert says, their study says that the milder Omicron is an evolutionary mistake, and that once that it is next variant may be the more lethal. So the reduced severity Omicron is obviously good news, but the next variant that comes, there will be one that will not necessarily have these characteristics and could go back to the severity that we have seen before, like the Delta. so that it is not the end of the COVID. So next variant, even maybe there may be the disease severity may be higher, though it is a hypothesis, there is no such hardcore evidence, but we have to be vigilant about that. So how do we protect ourselves? There is the one meme that is circulating in the social media. You can see is that the vaccinated twice, even the booster dose, even after that, that is a breakthrough Omicron infection. So the complete 2 dose or the booster dose, is it going to help? Or is it, there is also the report of the breakthrough infection after this booster dose, even the booster dose in UK or USA, and 2 completed dose. You can see in India, the 2, even the person, all of us now, most of the, we are infected even after getting the 2 doses of the vaccinations. So the the rationale and the inference that is going around regarding the vaccination is that first one is that the significant change in the spike protein, including the 15 mutation in the receptor binding domain, that leads to significant reduction in the neutralizing activity and from the vaccinated and previously infected individuals. So that's why there is the immune evading property of this Omicron. So the people are inferring that vaccine made from the older variant will not work. Then the another point is that the Omicron is causing milder disease, so it will act as a natural infection. We do not need a booster dose. It will infect the most of the people and the herd immunity will develop. And third one is that the present vaccine is not so efficacious in preventing infection, but it reduces the disease severity. But Omicron does not cause invasive disease, hospitalization, ICU care, or death. It is causing mostly mild disease. So why the vaccine is needed? So vaccine is nothing to do with the Omicron. So these are all the things that is going, there's questions that are circulating around within many of us. But is there any evidence on the UK data? This shows that what is the hazard ratio of the hospitalization of the Omicron and Delta in patients with according to the vaccination status. We can see here that these are the dose. The 3 means this is the booster dose as given. And even you can see after 2 doses of after 25 weeks, the hazard ratio of hospitalization is Omicron is much higher than the Delta. But after taking the booster dose after 2 weeks, the hazard ratio hospitalization of the Omicron, though it is still higher than Delta, but it decreases from the only 2nd dose. But also, you can see here the hospitalization rate and the disease, severe symptomatic disease here, you can from the Omicron and the hazard ratio and the vaccine effectiveness. You can see after the booster dose, the odd ratio of the symptomatic disease is decreased significantly, and vaccine efficacy of hospitalization increased to 88% from 52% of 2 doses versus 88% the person who has taken the 3 doses. So that is the one of the evidence from the UK data shows that the booster dose vaccine does protect against the Omicron and it reduces the hospitalization. And so this is the study from Pfizer. You can see here, there's the original virus and the Omicron. The people who has got the 2 shots, the antibody levels are much lower in Omicron. But whenever it is given a 3rd shot of the booster, there's the neutralizing antibody increases the 25 times in a patient who have got the booster. And it has been shown here in that, but remind it is that this is the only 2-week data. We don't know how long it is going to help us in the long run. Like the original vaccine, even against the original strain, it is not affecting more than 6 to 9 months after take booster. So how long it is going to help even after the booster, you still really don't know. And this is the one Twitter that has been circulating that it knows from this is the UK data, USA data, that the COVID patients that are hospitalized, that 76% are unvaccinated, and 24 had received 1 or 2 shots, and 0%, there is no patient out there who have got booster dose and hospitalized. So this is the one of the data in favor of this vaccine, booster dose vaccination. So the how long it is going to protect us, still we don't know. That the time will tell us. And the few scientists is telling there's the vaccination plus herd immunity plus Omicron, that is the natural vaccine, will the end pandemic. So is it really so? Till we don't know, but that is the no hardcore data to believe it, but we have to be vigilant on that. So Omicron, so how do I know that I have had it? So how the test is going to help, the present diagnostic test, is it going to help? It is going to detect the Omicron. So general recommendations on the RT-PCR is that the test performance may be impacted by the certain variants. So the states that targets the single gene, they are more susceptible to change in performance due to the virus mutation. So if the mutation occurs in a certain particular gene and that test detect that gene only, then that test will not detect that particular variant. So the test which the kit that can detect the multiple targets, they will detect even that there is some mutation in some genes. So a gene dropout may occur due to different mutation in other variants and may not be specific for that Omicron variant. So this gene dropout, that we calling it S gene dropout, because there is huge number of mutation in the S spike protein. So that is the RT-PCR will not detect the S gene. So that is called the S gene dropout, but it is not inherent to the Omicron only. The other variants like alpha also have this S gene dropout property. So if it is, though it is alpha is not circulating at present. So if there is S gene dropout, we can have an idea that it may be an Omicron. So this red line you can see is the test which can detect the multiple gene. The detection pattern showing the dropout or failure of the affected target may help to signal the presence of the Omicron variant. And it had to keep in mind that the N or S gene dropout are typically not observed in the Delta variant. So if there is the now at present, if there is the dropout of the S gene, then we can we can assume that it is the Omicron unless proved otherwise. So you can see here that the RT-PCR test is being conducted here. So this, if the test can detect this all three genes, the spike, the nucleocapsid, and the E antigen. If the S antigen is detected, if yes, it is unlikely to be Omicron, but it is no, then it could be Omicron. But you can know that the Omicron has two variants. The Omicron 2, they don't have this much of spike protein mutation. So this S gene drop out the Omicron 2, but it is not circulate. It is not a prevalent circulating variant. So it may not be detected by the S gene target failure or S gene dropout. So if you can look at the report of a particular patient, then if you look at here, there's the two genes, that the N genes and the ORF genes are detected here, but there is the S gene, the RP is not detected here. So you can call it the S gene dropout. So alpha and gamma variant can also have S gene dropout, but they are not the prevalence, they're not circulating in the population at present. So S gene dropout at present indicates that it may be Omicron. So, and you know, there's the ICMR approved the first kit that is detected by of Omicron by Tata, that is called Omnisure. Now it is marketed and the cost is just ₹250. You can detect if it is positive, then it indicates that is Omicron is present. So according to the case definition of the Omicron, this term, you will find that the S gene target failure. The confirmed cases are that cases that are detected by the genetic sequencing. But probable case, if the patient have this S gene dropout or S gene target failure, then it is termed as the Omicron. This is the probable cases. So this definition is being used for this the statistical analysis and the public health health perspective. So this one of the this is called the S gene target failure is called the probable case of Omicron. So now this, you know, this new ICMR guideline has been published very recently regarding the testing recommendation. It says that is one of this confusing is that many of us are not still not clear or maybe this has been told categorically that the no emergency procedure should be delayed due to lack of test, and the patient should the asymptomatic patient who are going to undergo any surgical or non-surgical invasive procedure, including the pregnant woman in labor who are not hospitalized for delivery, should not be tested unless warranted or symptoms develop. So this is the one of the biggest change in the from the previous guideline. So any patient who are going to any emergency patient coming for a surgical procedure, not having the symptoms suggestive of respiratory illness, the test is not required before the surgery. And also the people who need not be tested, again, the asymptomatic individuals in the community or the asymptomatic contact in the community should not be tested, but the patient who have comorbidities and high risk patients should be tested, and the patient who are getting the discharge and should not be tested at the time of discharge. That was also there previously. Now, if you look at the clinical published data in adult world regarding the Omicron, regarding the severity of the Omicron. So this is the South African data, and you can see here from this table, there's the requirement of the oxygenation in the fourth wave of the South Africa. That is the recent wave in November, December in the South Africa. The hospitalization requirement of the oxygen therapy is less compared to the previous waves. Receiving the mechanical ventilation, admission to intensive care, length of stay and death, all are less. But you can see here that the 17.6% patient require oxygen therapy and 18.5% require intensive care. What does it mean to us? That in country like India with a high population, if this percentage of total infected patients require this oxygen therapy and intensive care, then it will be just unmanageable in our setup. Again, this terminology that I already told, this S-gene target failure versus non-S-gene target failure in South Africa. You can see here that the hospitalization was more higher in patient with this non-S-gene target failure than this S-gene target failure group. And you can interesting for this is the point of interest for pediatrician is that the children less than 5 years, the hospitalization rate was significantly higher in children with S-gene target failure variant. But if you look at this severe disease category, the severe disease category does not differ from these two categories, this S-gene target failure or non-S-gene target failure group. Again, this was another USA data. You can see here, there's the hospitalization, emergency visit, hospitalization, ICU admission, and mechanical ventilation are much less in Omicron variant than the Delta cohort. But, and also this, if age-wise distribution, if you look at that, I will just look at this highlighted point. This 12 to 17 years, this age group, the hospitalization in the Omicron and Delta, there is not much difference. So it is just 1.21 in Omicron and is 1.93 in the Delta. But for other age groups, there is huge difference in hospitalization and ED visit. But this adolescent age group, 12 to 17 years, there is no much difference between the Omicron and the Delta. So now coming to the treatment, you can see that these are some prescriptions going to the social media, WhatsApp group. So you can see the patient with a mild disease here, patient have given the antibiotic and even the ivermectin. So though this being rejected from all the all the guidelines, so now still it is being prescribed and in different by the practitioners and the doctors. Even you can see this milder disease that they should not investigate the patient, but here in this prescription you can see the patient a mild disease, but patient has been ordered for investigations like CBC, CRP, and D-dimer, and the result higher mildly elevated CRP or mildly elevated D-dimer just got the create the anxiety even to the patient and doctor, and unnecessarily starting the steroid or the low molecular weight heparin. And you can see here there's one drug, this molnupiravir is advised for this patient with mild disease, 36-year-old without any comorbidity. So these are the prescription variation in the prescription you can see, but what to do? So actually the basic the treatment guideline in the patient who are not in the high risk group, in mild, moderate, and severe, the treatment guideline that was previously in the Delta previous pandemic was almost similar, except this isolation period that has been reduced to 7 days in the patient who are in home isolation group. But otherwise, it is mostly similar. So, but what is the difference? What should be our future management plan? So there is a shift in the management plan in the pandemic. So the people are thinking, the scientists are thinking that we should treat it like a more influenza-like illness, that we categorize the patient according to the syndrome, this ABC, according to the risk of the patient, but we should not treat the patient, every patient. So that is the thing that people are saying, that don't look at the total caseload, keep an eye on the hospitalization rate, and protect that an unvaccinated population who have not got any vaccine, and protect the high risk population. So this pandemic is now going to be the pandemic of the high risk population. That population should be protected. So what are the drugs that are available to, if we can use the patient, non-hospitalized patient with mild to moderate disease, and patient who are on our high risk group that has risk for going to the severe disease and death. These are the drugs that are recommended by the panel of the expert by the CDC. That is the one called the nirmatrelvir versus boosted with the ritonavir. Then the second is the another monoclonal, the sotrovimab. Then third is the remdesivir. The remdesivir is back again. The remdesivir was after the solidarity trial, WHO omitted the remdesivir, but it is coming as a preventive measures in early disease, but not in the moderate or severe that we are using previous waves. Then the molnupiravir. Now it is added this 800 mg once orally twice daily for 5 days. But it should be kept in mind that the molnupiravir should only be administered when the other three options are either not available or could not be used. But should we use to children as well? These are the, and is there any recommendation for using in children, and what are the categories of the patient we should use, and when should we use? There are the questions, there are many controversies are there. But if you look at very carefully to this table, this nirmatrelvir and the ritonavir and the sotrovimab, these two drugs are not available in India. So, and when it will be available, we don't know. So these are this remdesivir and molnupiravir is now available. And you can see here, these all drugs are approved in children aged more than 12 years, and molnupiravir is approved only in children aged 18 years. So children less than 12 years, none of the drugs are approved, and they should be used within the first 5 days of the onset of the symptoms. Only in case of remdesivir it can be used within the 7 days of the symptoms onset. And if you look at the efficacy here, the highest efficacy with this nirmatrelvir and the ritonavir, followed by the sotrovimab, then the remdesivir, and the look at the efficacy of the molnupiravir to reduce the hospitalization death is just 30%. And you can see here, this due to presence of ritonavir, this drug has the highest drug-drug interaction and hepatic and renal impairment of the contraindication for using this drug. And this sotrovimab monoclonal antibody is not available in India. Remdesivir is again we cannot use the patient with have hepatic dysfunction and the low creatinine clearance. And I'm going to the detail in the molnupiravir. But the remdesivir we have used in the children, and the CDC is approved in the even in the children less than 12 years under emergency use authorization in patient with COVID who required higher increasing oxygen therapy. But the children with a mild disease with high risk population as a preventive measures to use this drug to prevent the going to the severe disease has not been studied in children less than 12 years. So you have to take a call before that, especially in the patient is high risk group. So you have to keep in mind that all these drugs, the trials I have kept these words in capital and underline that you have to keep in mind that the efficacy of this drug has been studied in unvaccinated, non-hospitalized patient with mild to moderate disease who are risk of progression to severe disease. So it is not for a healthy children or healthy population. And this study was not done in vaccinated. Those who have already antibody in their blood, how they are going to help this drug, we don't know. So molnupiravir, again, it is mechanism of action that it induces the error in the genetic code of the replicating virus, that it induces the lethal mutation, and that is the death of the virus occurs there. Molnupiravir is expected to be active against the Omicron also, but it is not been studied. It has been studied in the Delta and other variants, not studied in Omicron, but it is according to its mechanism of action, it is expected to work on Omicron also. It is contraindicated in the first 10 weeks of pregnancy. Even after that, we want to give it to the pregnant woman, then it have to have high risk consent to be taken, and thus there is significant phytotoxicity. And the men with reproductive potential and also the women in the childbearing age group should abstain from sex and use the reliable method of contraception for duration of treatment for at least 3 months after the last dose of molnupiravir. Because we are also seeing that most of the adults and our relatives and the near ones are also infected. So do not just inadvertently just advise the molnupiravir unless going to the details of the drug. So these are the cautions that you have to keep in mind. There's the efficacy is less. It should be used in patient with who are at high risk for going to a progressive disease and has at present mild disease and within the first 5 days of onset. And these precautions should be kept in mind. So these are the high risk populations that we have a next panel of discussion of these high risk populations. I'm not going to the details. So these are the patients who are going to have severe disease and death. So these drugs are only for this particular patient population, not for any healthy child population. So monoclonal antibodies against the SARS-CoV-2, there are 3 monoclonal antibodies that is approved, but the first 2, one that is the one of these things are available in India in the name of Regeneron, that is the casirivimab and the imtemivib, but this is not approved in the Omicron variant. Only this sotrovimab is approved for the Omicron, but is not available in India. So forget about the monoclonal antibody, this Omicron era now at present in Indian scenario. So I'm not going to the details. So specifically, so there is very limited role of this monoclonal antibodies or the antiviral in at the present scenario in the treatment of the children or especially in children, but in the adolescent age group more than 12 years or in adults, they have some role. If the patient have high risk group, there is risk of going to the severe disease, and the patient is in the mild disease spectrum and within the 5 days of the treatment. So if there is genotype is not available, then remdesivir is one option. If the Omicron variant, then the sotrovimab, but it is not available. This non-Omicron variant, then there is role of Regeneron or the casirivimab or imtemivib. But most of these drugs are you have to keep in mind when to use and which patient, and specific indications should be kept in mind. Also, this side effect and contraindication should be kept in mind. So last part of this talk, this MISC after Omicron, is there any data? There is absolutely no data, but our pediatricians are always concerned about this MISC data. And this is the very preliminary studies from the USA that study shows that this Pfizer vaccine has given some protection against the MIC. You can see there's the out of the 102 patients with MIC in 12 to 18 years age group, the patient who are double vaccinated, only 5 required hospitalization, 5 had MISC and required hospitalization, and patient who got the 2 booster dose, the critical patient requiring the life support is nil. So this vaccination, though this study has many fallacies and many limitations, but it's a very early data that shows that the vaccination prevents the MISC. There is the one thing that we are discussing our panel discussion in long COVID in our clinical meeting in the meeting in WB Pedicon. That is the USA data shows that the incidence of the diabetes mellitus in children in adolescent after this COVID surge, and this have been shown in this study. This is a very early study that the COVID-19 children, in comparison to the other ERI cases and non-ERI cases, the incidence of the type 1 and type 2 with the odd ratio of the getting the diabetic ketoacidosis diabetes is high in children. So that is going to we have to be very vigilant and keep in mind this is happening, and we highlighted that in our panel on this long COVID syndrome. So key points that to be keep in mind that the Omicron is a deviant from the normal mutation pattern of SARS-CoV-2. There is higher transmissibility and the short doubling time, that is risk of overwhelming, that may lead to the risk of overwhelming the healthcare system. Although the present data suggests the low hospitalization, we need to be very vigilant and focus on high-risk population on management perspective. Risk of MIS after Omicron may be a point of concern for pediatricians. Thank you. If there is any question, then I can take later on.
Thank you, Mir. Thank you so much, Professor Mir Sarkar, for your excellent deliberation. There are a few questions. Can I read them out? Hello?
Yes, yes.
Can I read the questions out?
Yes.
Just a minute. Just a minute. I'm sorry, the questions are not coming on my screen, but Shweta, can you help me out?
Madam, you are muted.
Indranil, I was thinking, shall we take the questions at the end? Because some of these may be answered during the course of the interactive session. What do you think?
Yeah, I think that is better.
Okay.
So,
I will write the answers in the chat box itself. Okay, just go ahead.
Okay,
But
Professor Mir, thank you so much.
Mihir, please stay with us because there might be some more questions also during
Okay, definitely, madam.
Yes.
Yeah. Okay, now I hand over to our moderator of the next session, Dr. Sushmita Banerjee, for the excellent panel discussion that is going to happen now. Over to Dr. Sushmita Banerjee.
Thank you very much, Indranil. So, ladies and gentlemen, we have representatives of the different pediatric subspecialties with us on the panel. As Dr. Mihir Sarkar, as he mentioned in his last few slides, the management of COVID prevention and the focus seems to have shifted to what may be the high-risk patients. We don't really know. It is a new experience, this Omicron, to us. We don't yet know which of our patients will develop severe disease in this current wave. So far, I think all our experience is that it has been the disease has been fairly mild in children. But we look forward to hear from the specialists who are with us, who are dealing with children in their different subspecialties with high risk children day to day, what their experiences are. We would also like to ask them who they consider as high risk in their specific subspecialty. What would they suggest that the general pediatrician do to protect those patients? And if those patients were to get COVID, how should they be treated? So let us start. Of course, our chairpersons, we have two very experienced, very wise chairpersons, Paharida and Apurvada. Both of you, please feel free to interject and to ask questions and comments during the panel discussion if you feel there is a need. Can I ask all the panelists to unmute and everyone else, if you could please stay muted. So let's start with Dr. Shubhashish Rai. Shubhashish, we of course think of COVID as primarily a lung infection. And because of that, we think that our patients who have previously diagnosed lung conditions may be at higher risk. Have you found that to be so?
No, exactly. It is a contrary. What is being perceived or what is being felt that the children who are having some lung morbidity, they will have more severe COVID. But actually, the last 2 years experience have shown us that first of all, the COVID infection, all of us know because of various reasons, because of AC receptor lesser expression, severity of the disease is much less. What is the most common lung problem that we get in our community? It is the preschool wheeze or asthma or virus-induced wheeze. These are the three most common problems that we encounter in our day-to-day life. Now, if you talk about the asthma, if you talk about the asthma or preschool wheeze, it has been found those children who suffer from allergic disease with a high eosinophil count, they suffer less from COVID infection, because eosinophil cationic protein, there's a secretion from the eosinophils which may neutralize the SARS-CoV-2. And second thing, those children who are using inhaled corticosteroid, they are slightly immune from severe lung problems if they get infected with the COVID. So in fact, if you divide, it is not my experience, all the pediatricians here, if you ask them, if we divide the last 2 years period, starting from March 2020 to June 2020 or August 2020, there was no respiratory problem at all. No patient with cough, no patient with wheeze, no patient with any respiratory problem came to our clinic. From August 2020 till or September 2020 till January, we got some cases of wheeze and bronchiolitis. But again, the number was much less than what we used to get in other years in 2019, 18, 17. Then
Probably
again,
because children were stuck at home and not
they were at
exposed
home,
to much allergens.
more vigilant. Parents were more vigilant so far as the hygiene is concerned. They were using masks whenever they are going out. No school, because the flare you see in a pediatrician's clinic is basically due to viral infection. We don't treat diabetes. We don't treat hypertension. There is no chronic patient for us. So the pediatrician's clinic were full of patients because of viral infection. And as the children, the single most important cause, the children were not going to school. So there was no cross infection. Then again, during the second wave, there was a dip in respiratory cases, and again a wave of bronchiolitis we have seen during pre-puja time. But again, the total number is much less. So in a nutshell, respiratory problem in a children is not an additional risk factor. In Western world, cystic fibrosis, primary ciliary dyskinesia, those children who are suffering from these two diseases also, it has not been found that it is an additional risk for COVID death or admission. But uncontrolled asthma and COPD is a greater risk for death and hospital admission in adults. Two respiratory illness I have searched the literature which are associated with more lung morbidity. One is chronic lung disease or bronchopulmonary dysplasia and bronchiolitis obliterans. Rest, we are happy with the situation. Total number of cases so far as the lung infection or asthma, uncontrolled asthma, much less nowadays.
Can I ask you about the budesonide inhaler therapy? Many adults are being prescribed this as soon as they are detected to be COVID positive, regardless of whatever their lung symptoms are. So almost as a preventive. Is this something that is being done or recommended in children?
Well, in children, there are only 2 or 3 studies. And it may sound very funny. I always take the pharma company studies with a pinch of salt, be it from Pfizer, be it from Moderna, be it from Cipla, whosoever, because they can do anything for their profiteering. But it has been found inhaled corticosteroids, especially budesonide, reduces the expression of ACE2 receptors, and to some extent also transmembrane serine protease receptors to some extent. So in mild to moderate diseases, it may help from progression to moderate to severe disease, that much. But you cannot depend, but oral corticosteroid will not help you. It is only the inhaled corticosteroid may help you, and that also in milder diseases.
Okay. The second risk factor we think after lung diseases might be cardiac diseases. So going on to Dr. Amitabh Chattopadhyay, you have a lot of children with congenital cardiac abnormalities. Your institution did a cardiac transplant recently in a child, I think. Many of us have patients who incidentally also have a VSD or some other congenital structural heart defect. Are they at greater risk? Should we be taking any greater precaution in these children? How should we deal with this group?
Madam, to be very frank, we though it is mentioned that in children, and likewise, sir said that in pulmonary diseases, the pre-existing pulmonary disease might be a greater factor, greater risk factor, which is obviously true. And though it has been mentioned that congenital heart disease or any cardiac disease is existing cardiac or congenital heart disease is a separate risk factor. Till date, we haven't luckily found anyone who is suffering from COVID-19 effects on the heart having a pre-existing congenital heart disease. We haven't found so. It might be a coincidence, but we have found that cardiac diseases has come to us in two aspects, ma'am. One is, just like a Kawasaki disease or a Kawasaki shock syndrome with severe dysfunction and cardiogenic shock. And the second one is a sequelae of the cardiogenic effects, that is a coronary artery dilatation and thereafter mitral valve or other valvular regurgitation. I'll deal with the second one first. The second one, very luckily, we have seen that unlike the Kawasaki disease, where the aneurysmal pattern seems to persist for a long time, and if they at all return to normalcy, they have some residual disease. But fortunately enough, all the coronary involvements in COVID-19 we have seen, they have come back to normal. The average time frame in our lookout has been approximately around 8 to 12 weeks. The first type, which I told, there has been a larger proportion of patients who have presented with a shock, especially with severe dysfunction. And as sir was telling, the ACE2 inhibitor, ACE2 receptors on the heart, they have actually attracted more of the disease to this particular segment. And these people, they have got, number one, severe dysfunction, which have been managed by fluid restriction and steroid, followed by IVIG, and obviously inotropic support and furosemide infusion. And in some cases, we did need additional diuretics in the form of metolazone. We have given inotropic support. Very few of them did need ventilation, but not much, as Dr. Mihish Chakra will also confirm that one. And we have had arrhythmias to some of the patients, and we have had got heart blocks in about 3 patients, of which 2 recovered and 1 needed a pacemaker. None of these patients had any other comorbidities as such. The presentation was within about 15 days of the commencement of the disease itself, and they were referred to us from other centers, like some of the government centers and some of the private centers. Most of them recovered with an average recovery time of approximately 2 to 3 weeks.
So these were within 15 days of the acute COVID infection.
Yes, ma'am.
And they had no comorbidities to start with. So this
no, ma'am. In children, in the population which you got, they didn't have any other comorbidities as such. The average age group which we got was approximately 5 to 10 years.
Can I ask you, Amitabh, something that is clinically a little bit puzzling to me? We are, when we suspect MISC, we are often doing the pro-BNP levels, right?
Yes, yes.
Pro-BNP levels we find are often quite raised even in the presence of normal cardiac function on echo. So is that of any significance, and what is the cause? Can you hear me? I'm sorry, the dogs are going mad.
I can hear you, ma'am.
Neighborhood.
Pro-BNP is used as a marker of cardiac failure, ma'am, which obviously is in incipient failure, it can be raised. But if it is a frank failure, like in either in COVID or even in a case of myocarditis of any reason, myocarditis from any other viral infection or anything, it will be raised in thousands. It will come in the 10,000s and 15,000 range. So that is used as a marker, number 1, as a marker, number 2, as a prognostic indicator, and number 3, as a therapeutic beneficial marker, ma'am. Whether the pro-BNP is gradually coming down or it is leading us to somewhere else, whether the heart failure is controlled or not, that is giving us. But I'd like to make one special point here, ma'am. The cost of doing a pro-BNP in our kind of a setup is quite high. So even we do a first report, but the follow-up report and all, we more rely on the clinical signs, because most of the people, it's quite costly to in any setup. So we do an initial one. If it is in thousands and 10,000s, we know that it is a case of myocarditis, and we depend on the other ones like troponin, LDH, CKMB. These are the common markers which we use. And the other markers we use. These are the ones. But as you said, in normal myocarditis from any other causes, we do have a pro-BNP very, very high levels. But the ones which we got from COVID, from the COVID-19 related ones, initially the pro-BNP levels were very, very high. The ones which came in almost a shock. Thereafter, they gradually came down within approximately 10 days, 7 to 10 days time with appropriate therapy. But we do use this marker.
Is there a cutoff level beyond which you would be worried? Because why I'm asking is we get the levels of 10,000, 15,000 in a stable child, and then it's like it's like you don't know what to do with that level. In a child who's hemodynamically stable, maintaining blood pressures, etc. So is there any meaning behind those levels, or any cutoff value that we should use?
It is a little bit unlikely, ma'am, to have a level of almost 10,000 and above with a totally normally functioning heart. It's a little bit paradoxical, because pro-BNP is a very sensitive marker, and once it is high to the range of the what you are telling, ma'am, in that case we have to keep a very close watch on the child, and if preferably admission, because this child may deteriorate all of a sudden. We have seen these cases, they deteriorate all of a sudden. So I would prefer the child to be at least admitted, even if it is not in an intensive care setup. Maybe there can be in a general ward setup, so that to keep an eye on the clinical markers, the pulse rate, the pulse volume, whether the child has suddenly started sweating or not, and whether the child distress has appeared suddenly or not. So these are the common things which we notice very, very carefully, even if the child is giving us a cardiac function on echocardiogram is almost normal, which you said, but the pro-BNP is very high. I would like to keep a very close watch on it, because we have seen the cases, the children, they deteriorate very fast. In some cases, they deteriorate within 24 to 48 hours.
Thank you. Dr. Dibyendu Rai Chaudhary, are you here? Dibyendu?
Yes, ma'am.
Yes, I can see you. So, Dibyendu, I know you have dealt with a lot of COVID patients. Many of our renal patients, nephrotic syndrome is so common. Many of these patients are on steroids of different doses. Several of our patients with glomerulonephritis are on other immunosuppressive drugs like tacrolimus, like mycophenolate, etc. In your experience in the last couple of years, have these patients who are quite significantly suppressed with steroids or other drugs, are they running into problems with COVID?
Okay. Thank you, madam. Actually, we have treated large number of COVID-19 cases. Among them, some were with some renal diseases, and we have some experience in our house and from the other houses also, in some papers also. So if we tell regarding the onset of the disease, whether there is triggering factor, COVID-19 is a triggering factor in the onset, or it is association, it is not till clear. So when we have got the case with first attack of nephrotic syndrome in a COVID-19 cases, we thought that it may be an association or it may be a coincidence. So answer is not clear yet, number one. Number two, regarding relapse also, our view is same. Now, what you have specifically asked regarding the immunosuppressive therapy, we have seen that there is, in our experience and what we have learned from the other centers also, that there is no need to change or stop or modify the immunosuppressive therapy if the patient has got COVID-19 infection. That will actually, there is no flare up of COVID-19 or anything with the immunosuppressive therapy. So we have to continue with the immunosuppressive therapy in a patient in spite of being affected by COVID-19 infection.
So in your experience, you've not had any bad COVID infections in children with who are immunosuppressed?
Yes,
that's the message. COVID-19 in adults has often been associated with renal problems, AKI and other even hemolytic uremic syndrome and other long-term renal problems as well. Have you found anything like that in your experience over the last 2 years?
Renal effect of COVID-19 is much more in adult and it is comparatively less in case of children. There are incidents of AKI, and we have needed PICU care for those children, but we don't have any need for renal replacement therapy in our center. The baby who have COVID-19 infection and AKI, in fluid, it is only with fluid resuscitation they have responded well.
So it has been a pre-renal,
Pre-renal mainly.
AKI
Pre-renal
mostly.
mainly. Yeah.
Okay. So similar question to Dr. Orpita Bhattacharya. Orpita, you are dealing with a huge number of patients who are on chemotherapy, who are immunosuppressed. Are you continuing with your chemotherapy regimes is the first question. Or are you changing them in any way because of this massive wave of COVID that is around us? And second question is, are your patients, do you think they are at higher risk? Are they getting COVID infections? How are they faring? Are you changing their managements?
Okay, I'm going to answer your first question first, Vishmita. The reason why we are not being able to deliver cancer care in a timely fashion to children who have COVID, and that has been the case ever since this pandemic has started, is not disease related. It is a logistic and an administrative issue. Unlike other hospitals, where a lot of the wards have been converted into COVID wards, where patients have been admitted for COVID, in a cancer hospital, cancer treatment has to go on because the cancer patients keep on coming. So though our hospital wanted to, it could not dedicate a very large area to COVID patients. So we had dedicated COVID area, but it was reserved for the very sick COVID patients. And a lot of adults, we know in the first and the second wave, became very, very sick. So what happened was that children who are well, who could, because that has been the experience with all pediatricians, that children were not really becoming terribly sick. They were having mild to moderate illness, but not becoming very, very sick. So were our children, they were having a little bit of fever or some cough or something, or sometimes completely asymptomatic, but they tested positive. We could not bring these children in to treat them.
Mm-hmm.
The simple fact that there was nowhere we could keep them. So to deliver chemotherapy, that usually goes on over several days sometimes, we didn't have a dedicated space for them. So there was no patient ward for treating these children. That was
So you
number
would
one.
wait for them to become negative before you started treatment?
Well, in the beginning, that was what the general recommendation was. And then it became 21 days of isolation. Then it became 17 days of isolation. Then it became 14 days of isolation. Now, fortunately, it's just become 7 days of isolation. So it is not so bad. The other reason was that even the children who were on maintenance therapy, so they were on oral 6-mercaptopurine and methotrexate, we often had to stop this oral chemotherapy, even though they were in isolation at home and were clinically well, because we didn't want them to become neutropenic. You see, when a child with cancer has fever and neutropenia, you have no choice but to admit them, be it COVID positive or COVID negative.
Right.
So all children with fever neutropenia, regardless of COVID, would be admitted and treated with broad-spectrum antibiotics. That is the policy across the world. Now, we did not want a child to become neutropenic and get admitted just because they had COVID. So because the system was being overwhelmed, so we had to stop chemotherapy. So in the first and second wave, during the first wave, we saw a lot of treatment interruption because a lot of children had gone home. Those who were on maintenance therapy couldn't come to get their intrathecals on time because of the lockdown. A lot of patients newly diagnosed patients who would somehow manage to come to the hospital, but were COVID now positive at presentation, had to be turned away because, in a COVID ward, when you're wearing all that PPE, I personally, though I've been doing this for decades now, I could not imagine giving an intrathecal chemotherapy to a 2-year-old under sedation in a COVID ward where I can't even see because my glasses are all getting fogged up. So these are just logistic difficulties. These are not biological or medical difficulties at all. These were just logistics. So what we saw in the first wave, we had about 100 documented cases of COVID positive in our children. In the second wave, because it lasted shorter, it was about 80 patients, and we had to interrupt treatment in most of them. Now, whether this is going to have long-term consequences, only time is going to tell. But what I can say is that we didn't really have any direct COVID-related mortality. What we had was, there was COVID and there was progressive disease. There was COVID and there was severe sepsis along with it. There was COVID and progressive lung fibrosis because of a pre-existing radiotherapy to the lungs.
Right.
And so those were the contributory causes rather than COVID itself directly. So that has been our experience.
Okay. Thanks, Urpita. Coming now to Dr. Arundhati Banerjee. Arundhati,
yes,
perhaps you could tell us about what the patients you deal with who you consider might be at higher risk of getting COVID. And you also, when I spoke to you earlier, you mentioned that there were some associations that you felt maybe due, some neurological associations that you felt maybe due to COVID. So maybe you could elaborate on these 2 points.
Yeah, thank you, ma'am. So first of all, answering the first question. So we have precisely 2 or 3 sets of populations, especially those having chronic neurological problems. In that, if we consider the neuromuscular disorders, then they are more at risk of developing severe COVID because of decreased respiratory clearance, because of respiratory weakness, and also multiple factors, of which many of them be on, like SMA patients, maybe on home ventilation as well. So these children, they should be, like we have a very high threshold for hospital and treatment at the earliest if they have any symptoms which are suggestive of any severe pneumonia. One. The other group of or subset of neurological patients are those like nephrological patients. We have a subset of patients like those suffering from autoimmune encephalitis and also of ADEM around chronic immunosuppression. So those children who are receiving more than 20 milligram per day of prednisolone for more than 10 days, they are on chronic immunosuppression and they have their HP axis suppressed. So for that, it is very much indicated for them to be stress dose of steroids if they happen to have any severe pneumonia. One. And as for, we don't really have any clear-cut guidelines as to the patients on chronic immunosuppression like rituximab. So, but as of now, during the first and second wave, we have continued with them and we have not had any extra number of patients or extra morbidity to these patients because of this immunosuppression. And the second, answering to your second question, ma'am, that there were some, both in the first wave and in the second wave, we had some non-specific neurological complaints in the form of irritability and encephalopathy. We also had some post-infectious arteritis and stroke that we had in our setup. We also had GBS and other cranial neuropathies, which also presented post-COVID. But as I already mentioned, that in order to establish a causal association is very difficult because in that case we would have to do an RT-PCR from the CSF or something like that, and we actually ventured and we tried, but RT-PCR was not standardized. Like the RT-PCR values that we get from our nasopharyngeal swabs and the oropharyngeal swabs, they are more standardized than the CSF RT-PCR. The other is thing, and what I found in world literature was in association with PIMS-TS, there are certain neurological components which are found to be very specific. Like we have got ADEM post-COVID, but if we have particularly the splenium of corpus callosal involvement, which is a radiological sign, which we have found, that has been found in increased propensity in children having neurological complaints post-PIMS-TS. So and also the incidence of encephalopathy is more in children presenting with neurological complaints in association with PIMS-TS. Besides, also myositis and occipital intracerebral hemorrhage has also reported in world literature in a Lancet study, which has been found. But of course, in our, like if we consider our data, we almost treated around 60 to 70 neurological patients. Mostly they were associations. Like we had a child with febrile fever and the child again presented with a repeat episode, excepting barring one or two in which we had a presentation of leukoencephalopathy, and we had an ADEM-like illness, and we also had a GBS, the Aman variant, which was also found in association. But the causal association, whether it is there or not, is
question about the vaccine. There are reports of clotting, CNS clots, platelet disorders, etc. in adults after receiving the Covishield or the AstraZeneca vaccine. Are you aware of any such issues with children? Because many of the countries have started vaccinating children as well.
Yeah, but in our experience, I have not had any experience. And
I even suppose we are just starting off.
So we are just starting, and the age group is also different from what I see. Perhaps it is beyond what I see.
Still has yet not started in children, actually. It is the mRNA vaccine as now the Covaxin is now.
Right.
But as for thrombosis, we had a patient with multisystemic involvement, MISC, and also thrombosis, in which the child had skin thrombosis. But as for CNS, he had some pre-existing neurological disorder with leukoencephalopathy and also presented with a fungal brain abscess in that child. So we didn't get, as of now, we didn't get a stroke or anything of the thrombotic manifestation in that patient, if we consider a single patient.
Thank you, Arundhati. Coming lastly to Dr. Prabhash Prashungiri. Prabhash, from what everybody has been saying, children overall, even the ones who we think are high risk, do not seem to be doing too badly. Now, you are associated with PICU care in an institute where there is a huge number of high-risk children being looked after. What is your experience? Are you finding patients with previous comorbidities, previously on immunosuppression, are they being admitted to PICU in greater numbers with COVID-related complications? And if so, what kind of issues are you facing, and how are you managing them?
Surprisingly, though we have managed lots of immunosuppressed patients as well as in nephrology unit, rheumatology unit, we have a hemato-oncology unit. A few neurology patients are also immunosuppressed, they are getting steroids. But fortunately, got only a handful of immunosuppressed patients that came out to be a case of severe COVID and admitted in PICU. In the last 2 years, also in the first wave and second wave, we were not designated a dedicated COVID hospital, but we had to manage few difficult COVID cases. But my experience in managing difficult COVID cases is very much limited because most of the cases have been managed by me in medical colleges. But still, we have managed almost 12 to 15 cases in severe pediatric COVID in pediatric intensive care unit. And most of them had no history of any immunosuppressive agents. Surprisingly, that many of our nephrology patients has developed COVID infections. Recently, a new nephrology COVID ward has been established that nephrology patients who are COVID positive, they're taken care in that ward. Few chronic dialysis patients have developed COVID, but none of them became very bad to come in the PICU. Right. Same is applicable for your rheumatology ward and hemato-oncology ward. To me, I think we should consider COVID in pediatric age group like another viral infections, like a parainfluenza or some influenza virus or RSV virus. So suppose a patient is getting a rheumatological medications or steroids and DMRDs or nephrology patients. He has some upper respiratory infection with parainfluenza. What we should do? We'll do nothing. But if you compare that 1,000 or 1,500 or 2,000 parainfluenza cases, 1 or 2 will be complicated. We have seen severe parainfluenza ARDS came in the PICU on ventilator, high frequency ventilator. But I mean, only try to mention 3 cases that we got. Recently, one cystic fibrosis patient, very small, 7 months old, cystic fibrosis, 3 kg weight, developed COVID infection and expired in the PICU. Another 2 cases, both of them are rheumatological patients. One was a type of MCDD type of disease some rheumatological disease not fully yet diagnosed, and one SLE patients. Both of them has been pulsed with rituximab. And we have seen severe COVID with hyperinflammatory response in these two cases. And remember these cases. These patients presented with a full-blown ARDS, full-blown multi-organ dysfunctions, very high inflammatory markers, CRP sky high, procal, NT-proBNP, everything sky high. We did every possible thing, ventilations, dialysis, even cytosol, but we're not able to salvage these patients. So now at the moment, from rheumatological aspects, we are a bit scared of giving rituximab to the patients. When it is absolutely necessary, we'll try to give rituximab, because rituximab is a wonderful drug in many nephrological patients as well as any rheumatological patients. For the last couple of years before COVID, we have downgraded our threshold for rituximab, that not responsive, give a rituximab, it will do just wonder. But nowadays, we are a bit scared of giving rituximab after seeing these two patients. These were on rituximab and developed severe COVID and expired in 3 or 4 days. We are not able to make this patient survive. So I have only to mention about all the immunosuppressive agents, like patients got steroids, methotrexate, MAVAP, azathioprine, even chemotherapeutic drugs like cyclophosphamide, vinblastine in the hematological ward. They have developed COVID, but most of them had mild disease. Only these two cases developed rituximab and developed severe COVID infections. It's not very easy to take the inference from these only two cases, but I think we need a great data whether the other centers, those who are giving rituximab, whether their kid develop severe COVID and acute COVID MISC-like features post-rituximab. Otherwise, we got all sorts of cases. Just I want to mention two things that about the NT-proBNP in MISC, there are no data that after which cutoff level we can see the NT-proBNP is sufficient, because we have seen few non-MISC patients that presented the MISC NT-proBNP were 2000, 1500 and 800. But it needs a lots of cardiac function, lots of cardiac myocyte to damage before getting a NT-proBNP level of sky high. So before getting echocardiological abnormality of decreased cardiac function, your NT-proBNP may be high. Number one. About the neurological cases, recently we got 2 cases of acute encephalitic syndrome where the CSF pan PCR was negative. No etiological agent has been identified, but both of them had been tested positive for COVID in nasopharyngeal and oropharyngeal swab. As Arundhati told that I asked the NICET people to run the CSF COVID-19 PCR, but it is not standardized for CSF. So I do not know whether this acute encephalitic syndrome is a causation or association of COVID-19. And definitely the incidence of diabetes mellitus type 1, specifically presenting with DKA, new onset diabetes, has been tremendously increased in last 2 years in our scenarios. We got 2 cases with acute COVID-19 positive with DKA and many other cases where the COVID IgG antibody is positive. Hence, we do not know whether they have the association or causation.
Actually, in nephrology world, there are several reports that rituximab has been used fairly safely in patients, but possibly we are using lesser doses with more interval between doses, possibly than you are using in rheumatology. Can I ask you about something that is everyone sort of wonders about a bit? Initially, during COVID care, there was this big issue about not using nebulizers, prefer to use inhalers, not using non-invasive ventilation because of the aerosol production. Any comments about that?
I don't think so. If you try to examine a kid in your clinic, those who have regularly vaccinated, he or she will cry. It has been shown that if the patient is crying, it will generate more aerosol than you give a nebulizations. So these things has not yet validated at this moment whether we need to avoid. But what is the threshold of nebulizations? Definitely nebulization will create some aerosols and increase chance of spreading of COVID-19 is more. But in most of the times, if you analyze the nebulization practice of ourselves, if you take 100 nebulization practice, you see that almost 90 of this nebulization practice can be avoided. So when there is absolute necessary, you need to give it. Right. When there's absolute necessary, you need to give NIV, you need to give HHFNC, everything. But if it is not absolute necessary, then better not to use it.
Subhashita,
Already the
were you-
studies have shown that the regarding the oxygen and the high flow nasal oxygen the delivery that we give with the higher rate, there is no difference in the aerosol generation of this procedure. Already the studies have shown. So, but we have to take the all precautions that the N95 masks, the face shield, that because then any aerosol generating procedure, we have to give that. We have to take that precaution, but at the same time, studies have already shown that there is no much difference in this infectivity of these two procedures difference.
Okay, can I now come to Dr. Shutapa Ganguly? I think Shutapadi is here. Shutapadi, will you tell us, will you say a few words about GI manifestations, particularly during...
Nebulization, can I come
sorry,
in for a
Subhashita.
minute?
Yes,
Just
yes,
one
of course.
second. Just one
Please,
second.
please,
I
please.
want to give a very loud and clear message. Nebulization, I am not talking about the nebulization in PICU where Prashun is doing, Provash is doing, or Mihir is doing. By and large, there is a preference of nebulization in the pediatrician. There is a perception that nebulization acts better than the MDI with spacer.
Exactly.
Theoretically, maybe the aerosol generation during vaccination when the child cries, but during nebulization, there are two types of aerosol generation. One is your medical aerosol and the other is your bioaerosol. And definitely, if the child is suffering from COVID, and especially if the child is being accompanied by the grandparents, then the chance of getting transmitted the virus from the child to the grandparents are higher. And it has been found that the MDI with spacer, until and unless the child is hypoxic, MDI plus spacer is as good as, if not better, than the nebulizer in tackling acute asthma in more than 90% of cases. So it is completely unnecessary to do nebulization whenever it is a knee-jerk reaction of the pediatrician. Whenever they see a child who is coughing with a history of asthma, in fact, nebulization is in two things. One is your medical commerce. The doctor can earn something from the nebulization. And second thing, in the nebulization, you do not have to wait for some time, or you have to spend some time, because you ask the assistant to plug on the nebulizer and you ask the parents to put the mask on the face. But if you want to give 6 puffs 20 minutes apart into 3 sets, which is the standard recommendation for taking care of the acute asthma, then the doctor should be vigilant and they have to spend some time and cannot ask money. And perception is also there in the mind of the pediatrician that nebulizers take care of the acute asthma much better than the MDI, which is completely wrong. If you go through the literature, all the literatures everywhere in the world, nebulization is being discouraged nowadays.
Thank you, Subhashita. Shutapadi, few words about GI involvement, particularly in this current wave, which seems to be very common.
Yes, it is a well-known fact that GI involvement is more common in pediatric population in comparison to adults. And even if the children are presenting with high fever, cough, runny nose, or stuffiness of nose, there is associated GI manifestation. Most commonly, there is anorexia and refusal of feeds. This lasts for long time. And also there may be the nausea, vomiting, diarrhea. I've seen many cases initially presenting with GI manifestations, diarrhea, vomiting, and later on developing cough and cold. Diarrhea may be the sole presentation of COVID, SARS-CoV-2 infection. And it is also from literature and from real life experience when children are presenting with diarrhea during this COVID pandemic season. And if we go for the nasopharyngeal swab test for RT-PCR SARS-CoV-2, it is almost always going to be positive. And these are the typical presentation, but never they're very severe. And one thing which is of concern, that the fecal shedding of the virus goes on for much longer period than when it is negative with the nasopharyngeal swab, maybe for 4 weeks, 5 weeks, and so on. But one thing is that the fecal-oral transmission, we are very much scared of the fecal-oral transmission, particularly in the elders who are cleaning the child or changing the nappies. But recently I have seen in the literature that though the SARS-CoV-2 virus have been detected in the stool by RT-PCR, but isolation of live virus and culture has not yet been possible. So whether the fecal transmission occurs or not, it is now not clear. Maybe there is a lung gut crosstalk and the gut is infected from the lung inflammatory X-rays and the cytokine-induced damage to the lung parenchyma. And also there are some uncommon presentation which we have to be kept in our mind, because sometimes the children presented with acute abdominal pain, exactly simulating appendicitis. Because as you all know that the ACE2 receptors are there also in the epithelial cells of the small intestine predominantly, not in the large gut, and they can produce terminal ileitis, presenting as pain, fever, abdominal pain in the right lower quadrant. And also the imaging shows the features of appendicitis, that is the dilated fluid-filled appendix, and even in the surgery and the histology, the same features come. The children may present with intersusception, just like the rotavirus infection. So there may be the phlegomonas ileitis. There may be lymphadenitis, mesenteric lymphadenitis. So these are the varied presentation, atypical presentation. But most common is the diarrhea, vomiting, anorexia, nausea, and refusal of feeds.
And I think overall just supportive management with rehydration and antiemetics, etc.
Yes, just hydrating the child using antiemetics as and when required, and temperature control are all that is required. Like me, I have the same experience. During the last week or 10 days, I have done a lot of telemedicines, and the children presenting with high fever and stuffiness of nose, I had to counsel the parents a lot to go for the COVID test. But when it is done, the whole family is positive, and the parents are telling that only last week I had mild runny nose, no problem. This is just a cold. But except in one case, in all the cases, the COVID RT-PCR was positive. Even presently.
Yeah. Yes, it is like really widespread and seems to be affecting, as you said, whole families at a time. Can I just ask just one or two comments from Dr. Rajiv Sinha and Dr. Priyankar Pal, if they are there? Rajiv, you have a lot of kidney transplant patients under your care. Are they being, I'm sure some of them are getting COVID, right? Are they getting sick? Are you changing the immunosuppression at all?
No. The short answer, like what
No
we
to
do
both.
is no to the second. So we are getting children post-transplant who are getting COVID. Fortunately, none of them have been immediate post-transplant, but usually maybe the earliest one was about a year post-transplant. And what we normally do is that if the child is having persistent fever, then we reduce or stop the MMF and reduce the TAC a bit, and then increase the steroid. And finger
How
crossed.
many patients have you had who have had significant COVID?
Not significant, no.
Okay.
Significant none.
Just fever.
Yeah, fever for a couple of days.
Fever and no pulmonary involvement.
Nothing. No, nothing.
Cardiac involvement.
And nothing. Just fever. And in fact, one of the patients had COVID last year, and then again had this year also.
Required admission? Anyone required admission?
None with KT required admission.
Okay. Now, is Dr. Priyankar Pal
and
here?
Just one thing, Susmita, about this MIAC and AKI. So there are reports that AKI is not that uncommon, and maybe we are not looking for it that much, that closely,
right.
Or maybe we are not implementing the exact definition, but AKI can happen to up to a third, I believe. That was reported in the MIAC.
Okay, I don't think Dr. Priyankar Pal is here. So can I now ask the chairpersons to come in, Dr. Amitabh Pahari, Dr. Apurva Ghosh, if you could give us your comments and ask any questions from...
Thank you very much.
from the
Before
panelists.
I allow my senior and mentor and guide, Professor Apurva Ghosh, to say something, I would just like to actually, say my sincere thanks to WBAP, Dr. Sushmita Banerjee, Dr. Indran Chaudhary, and whole of executive committee to organize such a wonderful COVID-related update for 2022. Particularly Dr. Mihi Sarkar and all the panelists to cover so many areas of COVID, and really actually in this meeting giving us a lot of hope, particularly when you're in the middle of this Omicron variant. With all your knowledge sharing with us and with our background kind of knowledge about what we have faced with COVID-19 infection since 2020, is that despite a lot of high-risk children that we look after, COVID-related morbidity is actually not that high in pediatric high-risk population. And we should continue to use all our armamentarium for different immunosuppressive or chemotherapeutic regimen for their specific indications. Of course, there will be some reservations about certain medications like rituximab, as Dr. Pipigiri has mentioned. And hopefully, the Omicron variant is not going to affect the children the way we actually thinking it will at some point. But there should be a word of caution. What Dr. Mihir Sarkar told us is that we should always continue to be vigilant about the evolution of this vaccine resistant and immune escaping virus mutations. And today, this Omicron might not look that sinister, and it might look just like a common cold-like illness in children. But tomorrow, another kind of variant might come into place, and this mutation might be at the molecular level, at the organism level, or maybe at population-specific mutation that might be affecting us in future. But for now, I am really hopeful that we are actually, so far, despite this large Omicron wave affecting our children, things are not really turning it into that way, but we should be continue to be vigilant so that we actually try to give as much protection, because as that has been projected that it will be a more of a pediatric illness in future. And may I ask Professor Ghosh to actually comment on how we should actually be thinking about the future and what he feels that we might be lacking in today's discussion, to give us a few ideas about how to go about it. Thank you, Sushmita. Thank you, everyone.
First of all, I must thank Sushmita for organizing such a wonderful, excellent program, especially choosing the speakers. I must thank Mihir for an extensive coverage on COVID, and all the panelists, they have covered their subjects very well. I've got really nothing to add, but I feel that we should not be scared of COVID, but that doesn't mean that we should take off our masks, and we should restrict our activities. And COVID, or rather Omicron, is not really a threat, neither for the adults nor for the children. And I don't know how long we should continue the telemedicine. And I personally am not a very strong believer of telemedicine. And that's one point I would like to mention, that should we continue telemedicines for the COVID patients? Because we are vaccinated and because it's not a serious disease, neither for the adults nor for the children. So how long we should continue this practice? But still, some people need to continue telemedicine, but I'm not a strong believer of telemedicine. I don't know what is your views and others' view is. I know I have raised a very controversial point, but I'm not a believer of telemedicine.
Can I add something, Sushmita?
Sure, sure.
When initially we see a patient in telemedicine with typical COVID-like symptoms, I never forget to mention the danger sign in writing, that if any of the sign is there, you immediately hospitalize the children or you consult me. So in that way, since this Omicron wave is very mild, and most of the children, I don't remember that any child has to be hospitalized, and all of them were cured without any antibiotic and only by hydration.
Tapadi, unmute yourself. Mute হয়ে গেল.
I'm telling that when I'm doing telemedicine initially in the typical COVID case, I never forget to mention all possible danger signs in writing, and also I explain the parents that if any of the danger sign is present or if the child becomes sicker, you immediately hospitalize or consult me. And in that way, I have never used any antibiotic, simply hydration and all the antibiotics and vitamins to satisfy the parents, just nutrition and all, and have patience. And fortunately, in this wave, third wave, nobody has to be hospitalized yet. But most of the patient, if I don't consult them, I don't do the consultation, they will run here and there and go to the homeopathy and Ayurveda.
No, I'm not saying that. I'm not saying that. The first thing, I just one experience that I will give when the telemedicine was started, and the first day one patient was consulted for a pain abdomen. It didn't work well. I'm not talking of COVID patients. I'm talking of in general.
In general.
And the next, in general, and in next day they came to me and I found an appendicular lump.
Yes.
So, so that's what I'm saying. I'm not saying that the COVID patients, yes, you can do a COVID patient a telemedicine, or you can do a telephonic advice only. But on the whole, as I'm saying, that the pain abdomen, especially, one should not do a telemedicine.
I think it is very, for us, where we see a lot of chronic patients who are on the immunosuppressants, who need time to time drug monitoring, blood levels, just maybe a CBC and a liver function test. In these kind of circumstances, telemedicine has been very useful, because then the child doesn't have to come just to show a blood report. So I think we have to pick and choose. Not every patient is appropriate for telemedicine.
That's what I'm saying. So for pain abdomen, abdomen,
no, never. Pain abdomen, unless I palpate the abdomen, I cannot give.
One should not be forgetting that pediatricians are actually doing telemedicine for ages. Because I don't think any other specialty doctors are actually answering their phone call for fever, loose motions, diarrhea for so much. So you are not even seeing the patient. You are just giving telephonic advice, even when they are actually not being ever seen by you. So telemedicine and pediatricians are always there. It's over telephone.
The terminology has become more formal.
I have seen Professor Apurva who's carrying 2 phones and answering very important calls even in the middle of meeting, because those are special patients. We all have got special patients who might be benefiting for telemedicine, particularly during lockdown, when they are not being able to come to the clinic. I have not stopped my clinic, but I continue to do my telemedicine for a lot of my patients who live far away and might be scared to come and visit Kolkata during this time. So yes, telemedicine has got its place, but I agree with both Professor Ghosh and Professor Ganguly that it has got its limitation. And if we are thinking there has been a need for that child to be seen.
Yes, pride is important.
Definitely advise.
Yes. I mean,
can I ask
a last question, Susmita? A lot of patients from Bangalore, Hyderabad, and others are doing this practice in West Bengal.
Okay.
Now, sir's point is very valid, Susmita. If I can come in, the consensus statement should be, if the patient on the phone, you think the patient might be a COVID patient and you are an aged physician, or you want to avoid COVID patients, only those patients you can teleconsult. If they don't have fever and other symptoms of COVID, definitely they should have a physical examination. And Sir is absolutely right. They are paying 1,000 to 1,500 rupees and the doctor is sitting in Hyderabad. You can never follow up with the doctor, and there are medical implications as well. If you cannot diagnose and if you haven't written in your prescription to follow up within 48 hours or something like that, you might land up in trouble.
Okay,
Anyway,
আমি
thank you. Thank you.
একটা প্রশ্ন করতে চাইছি to Dr. Mihir. You showed us some data that the third booster dose was effective to increase protection against Omicron. But the studies you showed were based on Pfizer. This was a UK study. What do the AstraZeneca vaccine, do they show similar results? Because that is very important for us. Most of us have had Covishield. Will the booster protect us from Omicron?
There are AstraZeneca studies also. They have also shown that the booster dose giving protection. I have not mentioned that in the, but I have that study downloaded. So that is the preliminary data from the Oxford University. They have shown that the
comparative study between the protection given by AstraZeneca against Omicron and Pfizer type mRNA vaccines Omicron.
No, it is a placebo control, not between the AstraZeneca and the Covishield or the Pfizer.
Because UK is one unique country where both AstraZeneca and Pfizer are available.
At the UK, they have studies on AstraZeneca and first dose and the second dose Pfizer. That is the and the booster dose Pfizer. That study is there. But in Omicron, there's this study between the AstraZeneca and the Pfizer vaccine. If it is increasing the protective power,
there was a discussion that the AstraZeneca actually gave more T-cell protection than the Pfizer one. Dr. Jacob John and all the Indian experts are on the EA but there are no studies showing the immunity, persistent immunity, how long the AstraZeneca immunity is actually there in Indian population. That is the problem.
No vaccine gives full immunity. I have many relatives. My niece and her husband has recently traveled from USA with a small kid, 10-month-old. She landed with severe cough and cold. So just I did telemedicine and asked to do the COVID test. It was positive. And both the parents with boosters, Pfizer boosters, they are now infected.
কথা যেটা আমি লোকাল আইএমএ থেকে ডাটা থেকে জানছি, সেটা একজন অদ্ভুতভাবে বললেন এবং সেটা হয়তো আপনারা বেটার বলতে পারবেন যারা বেশি পেশেন্ট দেখেন। তারা বলছেন যারা প্রত্যেক বেবি এফেক্টেড হচ্ছে তারা কি একটা বেবি এফেক্টেড হলে তাদের প্রপেন্সিটি অফ গেটিং এফেক্টেড ইন আনাদার বেবি ইজ মোর, এবং there are numerous people who are getting affected more in subsequent waves. থার্ড ওয়েভে কিছু লোক এফেক্টেড হয়েছে নতুন ভাবে, কিন্তু যারা সেকেন্ড ওয়েভে এফেক্টেড হয়েছে তারা কিন্তু বেশিরভাগই থার্ড ওয়েভে এফেক্টেড হয়েছে। এটা কি আপনাদের কাছেও এক্সপিরিয়েন্স?
সবাই এফেক্টেড, এটা তো
সবাই এফেক্টেড হয়েছে, কল্পনা
সবাই এফেক্টেড, কেউ বাকি নেই।
সেকেন্ড ওয়েভে হচ্ছে, থার্ড ওয়েভে
omnipresent, Omicron is omnipresent.
তাদের বরং তো বেশি হচ্ছে।
সেকেন্ড ওয়েভ escaped আবার থার্ড ওয়েভ।
হ্যাঁ
আচ্ছা একটু ইন্টারাপ্ট করছি। We have some questions probably that are still unanswered.
এখন মনে হয় নেই, আমি দেখলাম এখন আর নেই, বেশিরভাগই আনসার হয়েছে।
I have already answered. I have given the answer.
ঠিক আছে। আচ্ছা তাহলে আরেকটা কোয়েশ্চেন করছি। এই যে we are talking about immunosuppressed patients. We know that immunosuppressed patients often do not mount a good antibody response to vaccines. So does anyone know, Mihir, what can we expect now that our children are getting COVID vaccine? If they are immunosuppressed, should they have an extra dose?
Children, in adults also, the immunosuppressed persons that they have this, their antibody level will be there, but the T-cell immunity will be less. This the cellular immunity will be less in them. So the booster dose will be required to them if there's to increase this neutralizing antibody level, because their T-cell immunity will be less in that particular population.
Is there any recommendation like that, Mihir, in adults?
Extra
Adults,
dose.
they are
extra dose
recommendation is there any?
Not extra dose, but there's this booster dose that is, or the this precautionary dose, that whatever is being termed, that should be they are more eligible.
Above 60টা তো ওইভাবেই করা হয়েছে যে সো কল্ড দে আর হাই রিস্ক ইমিউনোসাপ্রেসড, এইভাবে ইনডাইরেক্টলি কিন্তু ওভাবেই বলা হচ্ছে
এখানে প্রশ্নটা অন্য what Susmita possibly asked. A lot of our children are actually on various immunosuppressive medications, starting from steroids to MMA to methotrexate to cyclophosphamide,
worldwide যেরকম recommendation নেই
calcineurins, and we are actually recommending them for vaccinations. We are not actually stopping them for having the vaccination, but also providing them with a guidance that the vaccine might not be fully protective the way we expect them to be protective in other children or adults. Like in MMF, a lot of our nephrotic patients are on MMF, and when I looked up into the literature, the protective antibody level was found to be in 28 to 30% only. It was actually done by rheumatologists. I'm sure that is actually possibly be reflected in all our patients on MMF, irrespective of the primary disease condition. Now, in Western world, when your antibody titer is not getting up, they have been qualified to have actually an additional dose. What I'm actually asking Mihir, whether even in our adult population, any such guidelines actually coming into place now when the antibody titer is not mounting and they are recommending additional dose, so that we can think about replicating similar kind of practice in our children in future.
Now from India, there is no recommendation for additional dose. They are just giving this booster dose or this precautionary dose. But if they require any additional dose, right, from the general population over the general population, that is no recommendation still now. And I have across the because I don't know actually what is the data in adults, if there any booster dose is giving and how it is being affecting. So my knowledge is limited here.
So we should be expecting the private vaccination and others to come in place to take us decision based on pure science rather than governmental decision. Yeah.
Right.
Mihir, I have a small question. So far as the Pfizer data that you have shown, the Omicron has come for 1 month. And the UK government has advised for a booster dose hardly 2 to 3 weeks back. Now, how this data has been generated that the booster will act against Omicron?
Booster in UK is going on more than 3-4 because more than 50% of the UK population have got booster. So and the booster is more than 50%, around 60% of the UK population have got the booster dose as of their data from this UK government website. And also they have given the data of the post booster dose of only 2 weeks. That is the 2 weeks post booster dose data. So that's why we don't know how long it will persist, though initial data showing the good result and it is encouraging, but how long it will persist in long run, we don't know. So that is the one fallacy of that point. We don't have any long-term data.
But is the greatest example is take that of Israel. They have got 4 doses. Still, they are predicting to have a huge Omicron wave very soon.
Keep a vial of vaccine in your freeze and take every day.
I think what is
12 doses.
Sublingual
I think what Mihir possibly deliberately didn't mention, because there are a lot of studies that is going on around the world about immune escape and different viral mutations developing, particularly in countries where there is good number of vaccine prevalence, even when they are actually having 3rd doses. And those countries, particularly in Europe and North America, they are actually getting a specific mutations of immune escape, and mutation of those viruses giving rise to further evolution of COVID viruses. And they're thinking after Omicron, whatever viruses are actually going to be evaluated and mutated, it will be possibly having less infection, but might be actually having more severity and vaccine resistant, and as well as native antibody resistant. That is something that we are all a little bit scared of. I'm sure because it might actually scare all of us. Me, despite knowing this, possibly didn't mention those evidences that's coming across from the Western world.
No, what's the science behind? Or is it speculation?
It's a speculation. There is no hardcore evidence as such, because this the one data from this UK group from the Dr. Ravindra Gupta. There's the proponent of that. There's the Omicron is a dust accidentally, next will be the more severity will be high. But that is they are on speculation on the basis of how the Omicron mutation has happened. They are thinking, is this the new virus overall, or this is a are accidental mutation. So next, it is not following the pattern of the usual mutation. So next mutation may be more severe. So that is the one speculation or hypothesis. So no hardcore data.
No, it's
Now, my
in
question-
lab. In lab, they have already started finding out this information in spike protein, further mutation in Y449S. And they have already suggesting that these new mutations are possibly in the pipeline. But what is actually interesting here, they are actually already saying these infectivity is going to be less on those viruses and they might sustain, but only in high risk population and maybe in children, they might be actually giving rise to more sinister kind of problem. So that's the hope that we should all be hoping for, despite further evolution and mutations still continue to happen.
Now, my question to Dr. Ghosh would be, is the Omicron the sterilizing dose, or are there more waves to come?
Nobody knows.
To me, I've seen all the statistical reports, first from Singapore, then from IIT Bangalore, then from IIT Kharagpur, Lucknow, everywhere, and nothing is actually predictive at all. So I don't think that we can predict, come what may, and we'll have to face that. I'm bold enough to face, and we'll have to face. I don't know really what will happen in next few months.
The Bible of SARS-CoV-2 is yet to be written.
Only one thing I know, that now you should not leave your country at all because you might be stuck up there.
History is going to tell us how we faced COVID-19 and where we actually went wrong. We have already found lots of learning lessons and lots of pitfalls that we have actually possibly gone through all through these epidemics. So many changes in different protocols, so many unusual medications that is used, so many iatrogenic complications that we are seeing. Most patients that we see nowadays, at least in children with COVID, is because of side effect of medicines they're already being taken for, possible very mild COVID illnesses. So
what about the total change in society, social structure, the children not going to school? It's been World War III, really, it has
those are possibly having more major impact on children than COVID virus itself.
Exactly. One of the most important things, Susmita, the autism diagnosis has been delayed for long, because these children, when they used to go to play school at 1.5 years, the teachers would have identified that, see, your child is not really normal. And these children staying at home, parents think, the first time parents, they think that this is normal. So they are coming very late to the pediatricians or to somewhere for the diagnosis. So that's what I feel, that it's really a problem for the autistic children. Early intervention is always helpful in autism. We all know that, but that is being delayed. So that's the problem of not having school.
And maybe the actual incidence of autism and autism-like behavior in children is also going up because of all those lifestyle-related changes in children.
FGID cases are going worse.
Absolutely.
Tomik wanted to say something.
Sushmita, I just have one very, possibly a very pertinent point. We have restricted our children from not going to school. That has been the policy. There have been pros and cons. But we must realize it is high time that this is the most vulnerable segment of the population now. It's the one population which has not received even a single dose. So all this talk about, whether Omicron is going to be fatal, or it can have some severe cases, or a future mutant variant is going to, why? From the WBAP, at least I think so, we can put in a letter to the West Bengal Ministry or even to the Central Ministry that keeping children at home, is not allowing them to develop a herd immunity, number one. Number two, it is affecting them, like what Professor Ghosh said, and in many ways, their psychological development has been grossly impaired. It's something which is not acceptable. And even in terms of infectious disease, if you're going to restrain the population, you will never be able to develop the herd immunity. So children not being allowed to go to school, even if we forget everything else, purely from the infectious disease point of view, we are not allowing them to get exposed. And whatever experience we have had, the incidence of disease and the incidence of complications is much less in children than the adults who are being allowed to go outside. So I mean, we have to pitch in for a really strong case for reopening schools ASAP.
See, Sushmita, the most vulnerable people are allowed for Gangasagar Mela. So they are allowed for Gangasagar Mela, and the least vulnerable population is not being allowed to go to school. So I don't know really.
So Mihir, this is a project to take up, and we will all support you.
Children are
School for children.
Children are not allowed to go to school because they don't vote. Had they had power, they vote.
I think Sushmita, I think we possibly
It's past 10. Is Indranil here? Indranil, please, bolbe. Indranil, just hold on a minute. Indranil, thank you, bolo.
Really big thanks to.
আচ্ছা কারোর কোনো কোশ্চেন আর বাকি নেই?
না বাবা, অনেক পড়াশোনা হয়েছে,
অনেক কোশ্চেন হয়ে গেছে।
ঠিক আছে, তাহলে গুড নাইট টু এভরিবডি।
Good night.
Many thanks. খুব ভালো।
We'll meet sometime.
Very good program.
এত পড়াশোনা হলো, ডিনার খাবে না?
Really enjoyed the association of so many stalwarts.
I think the dinner was due. We hopefully will be